Hey everybody, it's Dr. Eric Balcavage, and I'm joined by my co-host, Dr. Erica Riggleman. We're back for another edition of Thyroid Answers Podcast, and today we have another guest. We have Robyn Johnson, who is a functional medicine dietitian, and she's going to talk to us today all about amenorrhea. This is a topic that I understand, but I don't have a lot of personal experience with myself, but you guys can help maybe from that side if we need that kind of personal information. But Robyn, so good to meet you. Thanks for coming on the podcast. It's great to have you on. How are you today?
I'm great. Thanks for having me here.
So a little bit before we get started, we kind of get into our topic a little bit. Can you kind of give us a little bit about your background? How did you get into functional medicine, especially from a dietitian perspective? This isn't typically the training that you get as a dietitian is in functional medicine. And maybe to some degree, it's almost 180 degrees away from what you learned in school. So can you give us a little bit of your background?
Yeah, you're spot on with that. Totally different direction. And honestly, it's a personal story. Like many people who get into functional medicine, it was my own story that kind of shifted my lens. And I had psoriasis for 2 years in college. So I was covered in what looked like chickenpox. Super fun time to get that. And I did all of the conventional stuff, so much prednisone. My next step was an immunosuppressant drug, so Humira. And I'm stubborn. I didn't want to do it. So I started digging into what I could try with diet. And I was absolutely experimenting. And I ended up clearing my skin within 3 months. And I haven't had a spot since. That was over 7 years ago. So that was my first story. And then I also have an amenorrhea piece that came around the same time where I hadn't had a cycle in 6 months. I went to the doctor. I was told I had PCOS and recommended birth control and metformin. Again, I'm stubborn. So I asked a ton of questions and ended up getting some additional labs and a different opinion, and had hypothalamic amenorrhea, and also addressed that with food and lifestyle. So through my own story, I learned about functional medicine, and then I was at the right place at the right time at a school that had its first program of its kind in the country to teach dietitians how to practice this. And so I took the leap and just dove into that, and I've been moving forward ever since.
So did you have those two things at the same time? But
yeah, they really
considered them like different conditions, even though they really might have had a significant connection, right?
Oh, they totally overlapped. And yes, they're around the same time. And now, knowing what I know now, the whole thing makes sense looking at the whole person. But at the time, they were two different problems in my lens and the doctor's lens. But we're all fixed up now in those areas.
Right. So we're going to talk about amenorrhea today. So can you give the listeners a little bit of an explanation about what amenorrhea is, and a little bit of maybe some of the processes that may be causative in triggering amenorrhea?
Absolutely. So amenorrhea is essentially not having a period. Now there are two broad buckets or types. There's primary amenorrhea, which is never having had a period by the age of 16, so not ever having a bleed. And then there's secondary amenorrhea, which is not having a period for 6 consecutive months or more, but having had a period before. So I work more with the secondary amenorrhea types. And within that, there's a whole bunch of other categories or types. And it's typically caused by something that is impacting either the hypothalamus, the pituitary, the ovaries, or the uterus. And so we can kind of dig into more of those if you'd like, but some of the common causes for secondary amenorrhea would be, one is hypothyroidism. Another is hypothalamic amenorrhea. So it's really where the brain and the ovary communication isn't going optimally. There's PCOS, there's post-pill amenorrhea, there's high prolactin and pituitary tumors. So there's a whole bunch of subtypes. And then even within those, we have more rabbit holes to dig into, which is where it can be kind of challenging identifying someone's cause, because there is a lot of digging into that person's reason for not having a period.
Yeah, so you would maybe say that, what happens, somebody may get diagnosed as amenorrhea, and we just say that that's the problem, and we're going to try and manage that, versus typically in conventional medicine, so that would be the treatment. Hey, this is what you have amenorrhea, you haven't had a cycle, and so we're just going to try and manage that, versus what you're really trying to do, and what Dr. Eric and I try and do when we have people come in with these conditions, is the conditions that is the fancy name we put for it, right? But we really need to, what we really need to do is uncover what that underlying cause is. And there's not just one cause, right? Which is what I think you're trying to say, is there's multiple potential causes. So just because you get a diagnosis of amenorrhea doesn't mean the treatment especially in a functional medicine model, is the same, correct?
Exactly. And really the amenorrhea is the symptom. So if you look at my case, for example, I hadn't had a period in 6 months, and that was what they named the condition. And then my treatment was birth control and metformin, when the cause was really over-exercising, under-eating, high stress, and a whole bunch of inflammation that was also triggering psoriasis. And once you addressed those, the period came back on its own.
Yeah. What I love about you saying that is that you weren't saying that the thyroid was causing the amenorrhea, that it was all of those lifestyle things that probably impacted your thyroid physiology, but then impacted you to have amenorrhea. So a lot of, even listeners who have thyroid issues, they don't look at amenorrhea as a classic thyroid symptom, but it is. It is definitely a symptom that, they normally think overweight, losing my hair, constipated, tired, fatigued. But there's a reason there's such a hormonal link that goes along with thyroid issues, as well as that amenorrhea is definitely a symptom that goes along with thyroid stuff as well.
For sure. And even with the subtype of PCOS or hypothalamic amenorrhea, just like with thyroid, there's more questions to be asked. So when you get down to it, it typically is around food and lifestyle. Like those are common reasons that are triggering the symptoms.
Yeah. So when we talk about hypothyroidism from our perspective, we typically talk about tissue or cellular hypothyroidism, which is that, thyroid gland can be functioning fine. It can be pumping out enough T4, T3, but there's not enough T3 getting to the nuclear receptor. And that's truly what triggers hypothyroid symptoms, is the lack of T3 hitting the nuclear receptor. And we typically look at the cause of that as some type of stress or danger response, which would make a ton of sense why you would see hypothyroidism associated with amenorrhea, right? Because if you have chronic stress, like in your situation, right, I'm over-exercising, probably under-eating, not getting enough rest, I got a lot of stress going on in my life. You got all these factors going on, which are creating excessive stress or danger signals at the cellular level. And part of the protective mechanism of the thyroid physiology is to slow down metabolism in that situation. Hey, let's shut it down. There's a danger here. Let's slow down normal metabolism, save that. And then as we reduce thyroid physiology within the cell, that helps upregulate the inflammatory cascade and help trigger the defense mechanism. And maybe for the listeners, one of the reasons why we might not need a period in that situation is if you're under stress, if you're in danger mode, having sex and having a normal menstrual cycle is not on the high priority scale of things to be done. So you don't need to sleep, really. You don't need to have sex. You don't need to digest, right? Not if you're being chased by the proverbial tiger. So do you think, in thinking about what was happening with you during that time frame, that, hey, I'm putting all these stressors on, that was driving essentially not an abnormal response, but actually an intelligent response by the body, like, hey, I'm under so much stress and have such limited energy here, I don't need a cycle.
Yeah, at the end of the day, my body was not safe to have a baby, and that is why we ovulate. Whether or not you want a baby, that is why you're ovulating. And if you have suboptimal thyroid function, you either disrupt or maybe even prevent ovulation. So without ovulation, there's no hormones, there's no period. And there are many causes, like you said, that first signal to the thyroid can be happening. And thyroid and ovulation, or thyroid and ovaries, have a communication system. So if you're not giving yourself enough energy, or you're demanding a lot of energy because of so much exercise or so much stress, baby is last on the to-do list.
Yeah, I think it's a really, really important point for people to understand that many times what we see as the problem, in this case, we're talking about amenorrhea. It is the amenorrhea, as you said, is the symptom. The chronic hypothyroid symptoms, they're the symptom, but they are the sign. Those are the things that should be telling us, hey, there's a problem here, and it's not necessarily something that should be covered up with medication, right? And I think the interesting thing is, and maybe you can talk to that, is when you have amenorrhea, what's the typical treatment? Birth control, right? If you have a heavy cycle, what's the typical treatment?
Birth control.
Birth control, right. So, I mean,
All things birth control.
all things birth control, right? You don't get pregnant, birth control. You have an abnormal bleeding cycle, we'll organize it. You don't have one, we'll give you one, right? And so we put people on, we put women on birth control. And I think in many cases, we're doing a total disservice, right? We're just patting the female on the head and saying, hey, we'll organize it for you, just go away and be quiet.
Yeah, I mean, the birth control in cases like this, it's definitely a Band-Aid. It would not have fixed the problem at all. It might have made you think it was because it will give you what looks like a bleed, but a birth control bleed is not an actual period because you're not making your own hormones. And I think one of the things we need to do better is educate women, young women, about the value of their hormones so that they're looking at their health differently. Because sometimes if you don't have a period, some women might think, no big deal, that's one less of an inconvenience. But there's so much value to it. It not only is it an indicator of your health status and gives you information on what's going on, but it is your hormones. Like, you're having a period because you're making hormones, which is so important.
And I think in our society, we're not taught that, and we're not empowered to know that our cycle is important. And I see a lot of women in their late 20s or even mid 30s who want to get pregnant, and they're like, okay, it's time to come off birth control. I've been on it since I was a teenager because I had abnormal cycles, and they just put me on it, and I've just stayed on it because I was going through college and I wasn't ready to have kids. And they come off birth control and they can't get pregnant. And then there's like a panic and a frustration of, I'm in mid 30s. I need to get pregnant. My time's running out. And they didn't realize that they never fixed the problem that was going on 10, 15 years ago. They probably had the start of thyroid issues. They had hormonal issues, and, taking the birth control, yes, made it look like they had a normal cycle for 10 to 15 years, but now we got to backtrack and fix all the stuff that's been going on for 10 to 15 years. And it can be really frustrating to a lot of women who want to have a baby.
Yeah. And there's sometimes some repair that needs to be done when coming off birth control, and even getting that brain and ovary communication going again. And for some women that can take a year or more.
So what would you say if we had to kind of narrow this, maybe some of the causes of amenorrhea down to maybe 5 or 6 or 7 primary causes? What would you say would be the primary causes? A woman struggling with amenorrhea, what are the things that you would say to her, hey, these are the things we got to look at first. These are probably the most likely things.
Yeah, I would say eating enough or unintentional undereating is a big one that I see with clients. Over-exercising, general stress level, whether that's perceived stress or past trauma or current lifestyle stressors, poor blood sugar or high insulin resistance, and then hypothyroidism. So even some of those relate, like undereating can relate to hypothyroidism, but those are the ones that I see most often with clients. And again, a lot of it relates to that foundation of diet and lifestyle.
So can we build off that a little bit? So, because somebody might say, all right, but so what's under eating, right? I want to do intermittent fasting, or I want to do time restricted eating. Is that under eating? What classifies as under eating? Should I be eating 3 meals a day and 2 snacks? Should I be eating 1 meal a day, 2 meals? What's under eating for me?
Yeah, that's a really good question. I'm glad you brought that up, because that's going to differ from woman to woman. But in general, we've got to get rid of this 1,200 calorie mindset. Women, when you're eating a green smoothie and a salad for lunch, that's not enough. That's not enough food. That's not enough volume, especially if you're doing exercise, whether it's running or CrossFit or strength training. We have to be eating adequate food. So if I don't really do calorie counting, I don't like that approach, but I think for some women, it helps to start to put a number to something, to know, well, where are we starting? And most women need to be eating closer to 2,000 to 2,500 calories. And a lot of people that I see come in eating sometimes 1,000 to 1,500, and we're just not fueling ourselves enough for what we're expecting to do day to day, but also in the gym or with energy expenditure.
Yeah, so I think a lot of people with intermittent fasting, they think that because you're maybe closing that food window down to maybe 6 to 8 hours, that means eating less. And I encourage all my patients that no, that doesn't mean eating less calories. You still need to be eating your caloric intake for the day. You just need to squeeze it into a smaller window. And a lot of women will say, well, if I eat more than what I'm eating now, I'm going to gain weight. And so there's that kind of fear sometimes, and you have to kind of break that mold that you're your metabolism is not doing what it needs to do because you're not eating enough. And that if we actually, it's kind of like a fire. If we put more fuel in, the fire is going to go up, and that's really your metabolism. So, changing that mindset, and it's that fear component. They don't want to gain weight too. So, giving them the tools and kind of guidelines, I think, is important for a lot of these women who have these symptoms, who don't know how to eat, and just educating them on the right foods too.
Yes. And I have a lot of thoughts on this topic, because I'm obviously low carb and intermittent fasting, or an extended fast like once or twice a year. And there's a lot of value to that. We know that. But when it's pushed too far, it absolutely has an impact on the metabolism and hormones. And I see a lot of women coming to me after doing a lot of fasting and lower carb, or even keto, for too long, or restricting it too much. And then we're running into a problem. And like you mentioned, there can be fear there, because typically if they saw results, especially like weight results in the beginning, they don't want to stop, because they think that works. And we're forgetting to look at the deeper picture, that hormones still matter, and hormones still impact weight as well. So that fear place about the weight gain has to be addressed. And it's something I talk about with clients a lot. And there's also ways to increase your intake without seeing gain. And that's something that I have to teach a lot and educate on, because if they're so afraid of a scale change that they don't take action, there's never going to be success. Like, we're never going to see a change.
So I'm going to jump in there, because I think there's going to be maybe a little confusion, and I'll play a little devil's advocate, because we're talking a little bit about, okay, you need 1,800 calories a day. We need 2,000. We're not counting, right? But somebody says, hey, look, if you're saying I still need to eat the same calorie load, and I'm doing time restricted eating, there's no way I'm eating 1,800 calories in one meal unless I'm going to McDonald's, right? And so that's not going to happen either. And so one of the things I think is really important for somebody who's concerned about time restricted eating, and this just happened to me with one of my diabetic patients who is doing fantastic on doing some time restricted eating and almost on an anti-inflammatory diet. And her doctor's like, no, you need to eat 5 meals per day to manage your blood sugar, right? And she's like, yeah, but my hemoglobin A1C, my fasting blood sugar is better. Why would all that be better if I'm eating 2 meals per day and everything's getting better? Why should I go back to eating 5 meals a day and getting heavier and fatter and all those things? So I think, and Robyn, you can correct me if you, or debate what I'm saying, but I think for the average person, when you're considering what's going on, if you're overweight or obese, one of the things that I see as the biggest problem is that if you do calorie strict, if you're eating small meals all the time, trying to calorie restrict, and you're eating small meals but never achieving satiety, which means that you feel satisfied, that sends a different signal, more of a danger signal to the body, like there's not enough calories or not enough food coming in. That sends a different signal than when you eat once or twice per day and you eat to a point where your brain gets the satiety signals, like, hey, I'm good, I'm satisfied. If you do that and you do that's where time restricted eating really can make a significant difference with just low calorie eating, right? I'm only going to eat 300 calories per meal or 400 calories per meal. That seems to be sending a totally different signal. And so that there's not this constant lack of caloric intake and a constant lack of satiety. And so I think for the person who's overweight and obese, if you're eating 1 meal per day, you feel satisfied, you're not feeling those hunger cravings, you might be fine. But if you are a person who is like leaner and you're doing that, hey, I'm only going to eat a little bit because I want to stay skinny, and always kind of giving your body that signal like there's not enough food coming in, yeah, then you're going to be more of in a danger mode. Do you agree with that? Disagree?
No, I love that you said that, because you're speaking to two different people, I think. So the woman with amenorrhea who's been doing a keto diet and doing intermittent fasting and does CrossFit 4 times a week and lost her period, she needs to backtrack a little bit. We may need to take a break from intermittent fasting. We may need to increase calories. The person that I feel like you're talking more about is someone who's either fairly healthy or maybe more towards insulin resistant or PCOS type. And in that case, I actually may recommend some fasting and we may recommend lower carb, but that's what's so challenging about functional medicine, right? It's you have to look at the person, all their symptoms, look at their labs, hear their story, and then make a plan.
Right. People love the protocol. Just tell me what my friend came to see you and you gave him a couple things and that's all that worked. I don't need to meet with you. I just want you to tell me what you did for her and I'll do it and it'll work.
Right.
Right.
It's not that simple.
It is. It's not that
Definitely
simple.
is not that simple. And every person, like you said, is different. I mean, I've seen women that going on a keto diet has helped balance their hormones and their thyroid, but I've also seen women that was the worst thing that they could have done for them. And so I hate to say that sometimes it's trial and error, but sometimes it is a game of trying to figure out what's going to be best. You know, and if things make you feel terrible, it's probably not the right thing. And we've got to look to something else. I've even seen women who do better with more moderate carbs or even a higher carb sometimes in certain cases to help balance it out. But that's why you can't just look at your friend or, you know, the person sitting next to you and saying, hey, it works for them, it's going to work for me, because it may not. You have different things going on in the body. Your chemistry is different. You know, their genetics are different, and that all plays a role in what's going to be best for your body and what you've got going on.
Yeah, I love that you said it's trial and error, because it's absolutely okay to experiment. And I think that people need to be okay with experimenting, but then changing if it's not working. So if you're doing keto or low carb or fasting and you feel worse, it's okay to change it. We just get in these mindsets where we hear all the education, we listen to all the podcasts, and we try to fit ourselves into that, and it might not be the fit for you, and that's okay.
Right. And it's not when you do something, and Robyn, I'm sure you experience this in your practice, what looks like the right thing to do on paper, you provide that to your client and they go, that doesn't make me feel good. That gives me a headache. That makes me itchy. That's not a mistake. What that is a learning experience. We gave you that and that's what you experienced. An astute functional medicine practitioner is going to be able to say, oh, okay, if we do that and you're feeling more itchy as a result of it, then that's driving probably a histamine issue on top of your estrogen. Oh, you mean when you go for a run, you get really itchy? Oh, okay. Yeah, it's not me telling you to exercise that's a problem. The issue is you have excessive histamine. And that goes along with your estrogen issue, right? And so it gives us information. And I tell patients all the time, just because the bottle says 1 pill 3 times a day, that doesn't mean that's your therapeutic dose. That's just a kind of a gauge they need to put on the bottle. What your dose is, it may be 1, 2, 3, 4. Maybe it's none of those, right? But what we need to understand is, what do you experience? Some people, they don't experience much. They notice slowly they feel better. But even when their practitioner gives their client something to do and they don't feel well as a result, that's not always the practitioner did something wrong. It's just how your body may be responding to something. And it gives us and you the ability to understand, oh, okay, I see what my body's trying to tell me something here. Just like if you're gluten intolerant, you eat gluten. I get a headache and bloated every time I do that. Well, okay, what does that tell you then? I don't know. Well, it should tell you that your body doesn't tolerate it. You agree with that?
Oh, totally. That's why I tell clients all the time, this is a partnership, and they know their body better than I do. So any symptom that shows up is information. Just like not having a period is a symptom, getting hives or being super itchy, that's a symptom, and that's information that we can listen to. And then, you know, if it's too difficult or too challenging for someone to figure it out on their own, that's where hiring a functional medicine practitioner can help, because we look at things from a lens that, you know, we have more puzzle pieces to put together.
Absolutely. Can't hear you.
You can't hear me?
Oh, now we can.
Can you hear me now? Yeah?
A little bit. It's low.
How about now?
Yeah.
Yeah.
All right, good. So I don't know, you'll cut that one out,
Yes.
Erica. Make sure we get that one cut out. So let's get back into, we're talking about amenorrhea. We talked about some of the causes. How about we talk about, like, where do you see thyroid hormones role in hormone regulation? Maybe you can talk about that a little bit, and let's also kind of classify in that, hey, if you have glandular hypothyroidism, the thyroid gland's not pumping it out, then you don't have enough thyroid hormone. So when we're talking about thyroid dysfunction, we're really talking about what's happening at the cell. So cellular hypothyroidism is decreased T3 reaching that nuclear receptor. You can have that with normal glandular function. So when we're talking about hypothyroidism on this podcast, we're really talking about primarily what's happening at the cellular level, regardless of what the gland's doing and regardless of what's happening from a hormone perspective. So where do you see thyroid hormone's role in amenorrhea?
Yeah, it can come in a couple different ways. So low thyroid production can impact prolactin. So if you have high prolactin, then you have downregulation of ovulation. So you're not getting FSH and LH, so therefore suppressed ovulation. It can also come into play with insulin sensitivity, lower thyroid hormone, lower insulin sensitivity. Then you may be driving more towards that PCOS type, or maybe even cortisol reasons for losing thyroid, or losing your period. And then, I mean, this isn't so much cellular, but again, if you have total metabolism suppression and not getting enough total energy, ovulation and producing an egg, carrying an egg to ovulate, is a very energy demanding process. So is producing a corpus luteum, where you get your progesterone. So if you don't have enough total energy, then you're not going to get that ovulation, you're not going to get your period. So there's a couple different mechanisms in which thyroid can come into play.
And thyroid hormone plays a role in all of those. And so that's where, when we're talking about thyroid physiology, we're talking about thyroid as kind of the thyroid hormone in your cells as the regulator. If there's stress, if there's danger, your body is on purpose, it's deactivating thyroid hormone. It's reducing cell metabolism. And as Robyn said before, or just stated, that, ovulation, this whole process is energy demanding. And so if there's a stress response, if there's a danger response, and we need to divert that energy towards more inflammatory mechanisms, cell protection, by slowing down cell metabolism, we can essentially shut off processes that aren't mandatory and we really don't want to happen. We don't want a female who's not healthy or has a chronic infection or chronic danger signals or toxicity getting pregnant. That's not probably the best situation to bring a child into the world. And so the body is pretty smart. We have this innate intelligence in the body to be able to say, hey, we're shutting down those things that we don't want to happen. And instead, we're going to work on physical activity. So energy production and blood sugar regulation. So you need glucose from your food to drive energy. What helps get glucose into your cells is thyroid hormone. You have glucose transporters that bring glucose into the cells. Glucose transporter 1, 3, there's a 2 that works, but we'll talk 1 and 3 are your basal glucose transporters, which means they don't require insulin to get glucose into the cell, but they do require sufficient levels of thyroid hormone. If you're deactivating thyroid hormone in the cell, you can't bring that glucose at a base level into the cell. And then there's glucose transporter 4, which is insulin dependent. And even though it's insulin dependent, it still requires optimal levels of T3 in the cell to get it in. So the thyroid hormone, don't look at that as really let me just flood the system with more thyroid hormone. We got to look at it the other way, like, hey, man, isn't this really cool? I'm under stress, I'm under danger. My body's slowing down the thyroid hormone or deactivating thyroid hormone in my cells to fight the danger and prevent me from getting pregnant, right? And so it's a really neat process going on when you look at it from the functional medicine perspective.
Yeah, there's so much involved. And when you identify hypothyroidism as a root cause to someone's amenorrhea, you still ask more questions, right? That's not the answer. Just like you said, you don't just fill the gaps with more thyroid medication. It's why is that signal being sent? And then there's more digging into that stress bucket of many sorts.
Right.
So let's say a woman has amenorrhea. We know that there's the thyroid component to it. So, doing a thyroid panel or even a metabolic panel just to look at thyroid function is going to be important, but there's a lot of other causes. So what other tests can somebody run to try to identify what's really truly causing their amenorrhea?
Yeah, so there's going to be a lot of ruling things out, and initial blood tests can be super helpful. Things like blood sugar and fasting insulin, a full thyroid panel, FSH and LH, total cholesterol. I mean, cholesterol is a precursor to our hormones. So if you're not eating enough fats or you're not making enough cholesterol, that alone can be a reason for amenorrhea. So those are some basic blood labs. And then you could also do some specialty labs, maybe even looking at inflammation within the gut, looking at cortisol, and then asking questions. Did you recently change your diet? Have you recently lost a lot of weight? What is your day-to-day diet look like? Trying to get an idea of, is their blood sugar balanced? Are they eating enough? What's their stress level? How much are they exercising? So, and that's a lot of the functional medicine pieces, right? Putting together their story with the labs to really guide you in the answer. And then there may be cases where you need to get the big things ruled out, like prolactinoma or tumor on the pituitary gland, or prolactin is another a blood test that should be done that would probably guide that. But you're really going along ruling things out, and then that's helping narrow down your root cause.
Absolutely.
So definitely, if we take a look at, let's say we're taking a look at blood sugar, or we're looking to look at their general labs, and we'll talk about maybe some of the other hormone panel tests that are out there. If somebody's sitting at the other end and you're talking about, let's say, cholesterol, right? Everybody's been taught that the lower their cholesterol, the better, right? You don't need high cholesterol is the problem, lower the better. When you're looking at somebody's cholesterol level, is that what you're saying to them? Hey, lower is better? Or are you letting them know why a low cholesterol may not be a good idea? Because in conventional medicine, the lower the better.
I know. And I have to do a lot of re-education on that. I did that yesterday. I typically like to see a woman's total cholesterol above 180, like 180 to 200 or even more. And I've had clients that their total cholesterol was 130. And that's a big problem. You're likely not producing your hormones in that case. And so we have to look at diet. We look at why is that happening? And we really dig into the cause there, and also just re-educate so there's not so much fear around that number going up.
Yeah, I think for years we've told people that cholesterol is the bad guy, right? It's the redheaded stepchild in the room that creates all the problems. And in reality, elevated cholesterol, just like everything else, isn't the problem. It is the sign of the problem. You need thyroid hormone inside your cells to utilize glucose. If you can't utilize glucose appropriately through something you learned about in 7th grade science class called your Krebs cycle, then that glucose essentially goes back out of the mitochondria to produce cholesterol as hey, we don't need more energy. We can use this cholesterol to make hormones, to make cell membranes, to make all this good stuff. And so when we see the elevated cholesterol, we should have in our mind as physicians, maybe not as patients or the clients, that, that means I am bringing in more calories than my cells need. And now it should be going to make hormones, but I don't have a cycle. So something's interrupting that process. So if it was high, what's interrupting the process? If it's really low, where's the cholesterol? Most people think that, all the cholesterol in their diet or in their bloodstream comes from their diet, right? Mm-hmm. And that's not the case. It's really 25% of the cholesterol that's in the body is from what we take from dietary intake. The rest is what the liver is making. So we have to be concerned about what are you absorbing from a fat perspective? What's the health of your gut? What's the health of your bile acid? Are you able to absorb stuff? We probably need to look at triglycerides. Are they low as well? Which means we have poor absorption. So there's so much to look at, but definitely cholesterol. And that's the same for guys. I mean, guys aren't having amenorrhea. Well, we always have amenorrhea because we don't have a cycle. But we don't want, I see a lot of guys coming in today with low cholesterol and low libido. They're moody, they're irritable, and they're like, my doctor said that's good. Well, no, if your cholesterol is 120, how do you think you're going to make hormones? And they just don't have the knowledge base to know that that's bad because we've been taught the wrong things, right?
Right. So a lot of re-education there.
Yeah. So from a blood sugar perspective, what do you like to tell your patients? Because the lab high on a test may be fasting glucose, less than 100 on the labs. What are you looking at from a blood sugar perspective, a range for your clients to say, hey, if you're not in this range, you're not in the optimal range?
I like to look at blood sugar, but also look at fasting insulin. So, and both of those have conventional normals and functional medicine normals. So within blood sugar, a fasting range, an ideal in mid 70s to mid 80s. And then fasting insulin, I like to see that below 5. And so those are just giving us an indication of, how are you utilizing the carbohydrates that you're eating, just giving us an initial guidance too on, do we need to look down the lens of something like PCOS or insulin resistance potentially causing the amenorrhea, or maybe looking more at like hypothalamic amenorrhea. So once I've ruled out or done blood tests first, typically with that, I might also look at something like a GI map or an advanced stool test to see, is there something going on inflammation-wise in the gut, or is there something going on digestive-wise? Are you not digesting or absorbing the foods or the nutrients very well? I may look at a Dutch test, even though they're not cycling. That's something that can at least give me a better look at cortisol and stress response, and that definitely plays a role with amenorrhea as well. So those are some of the specialty labs. There's many, but those are the two that I would use the most.
Yeah, I think that can be difficult for somebody to take a look, if somebody's got, let's say somebody does have amenorrhea, right? And their functional medicine practitioner has recommended a Dutch test. They may be thinking just like you are, how am I going to figure this out? Because I don't have a cycle. I'm supposed to catch this somewhere between day 18 and day 21, right? So do you have recommendations for somebody that you typically, if they have amenorrhea, but you want to run the Dutch, what are the typical recommendations you might give them as to when to take the test?
I honestly I don't really run that right away. So if I run the Dutch on someone with amenorrhea, it's months in after, for some reason, not getting a cycle back. If we do decide to run it, I would try to have them see if we can catch ovulation at all. Like with temperature, I'd have them track their temperature or use ovulation sticks to hopefully get one. Otherwise, you really aren't looking so much at the sex hormones for that test. Then you would be looking a lot at the cortisol, cortisone, and adrenal response. Or, I mean, you may catch some estrogen metabolism, but the bulk, if you're not ovulating, the bulk of what you're catching in that test is going to be other markers.
Yeah. And if you address a lot of the other stuff, it may not even, like you said, be necessary to run the testing if you can get the cycle to come back on. So we know that we want to run some specialty testing, try to find what's causing the amenorrhea, and obviously address those foundational things. But is there something that people who have amenorrhea, maybe nutrition-wise or lifestyle-wise, that you would recommend to help get their cycle back or kind of jumpstart things?
Yeah, the first thing would be assess if it recently went away. Think about what's changed. So have you changed your diet? Have you lost a lot of weight? Have you been changing your exercising and adding intensity? And seriously think through that. And if there's some obvious answers there, listen to that and backtrack. So maybe take a break from exercise, maybe increase carbohydrate intake or increase fat intake or whatever it might be that has changed. And then start building balanced meals. So looking at meals that are stabilizing your blood sugar. So adequate protein, adequate fats, adequate carbohydrates or vegetables for fiber, and try to get some structured meals in there that are going to help stabilize that blood sugar. And take a look at your stress. If there's big life events that have come up and that's when you lost your period, that's a pretty good sign that there may be a stress response that's triggered it, in which case consider breath work. I love breath work, or meditation, or even therapy to help with that. And there are adaptogens and adrenal support too that can help, but really we want to start with the lifestyle stuff. And then sleep, of course, that's a big one. Got to mention sleep.
Yeah, I think those are key things to consider. I think more than anything else, when I talk to people who are struggling with amenorrhea, I see more of that in my obsessed athlete category, right? And they may not even be the athlete, but the person who's really obsessed with their size and trying to exercise all the time to be skinny. And they don't want to eat anything that's got fat in it because they don't want to put any fat on. And that's where I see a lot of this kind of, it's really driven by lifestyle and behavior habits, right? And for the vast majority of people, eating healthy fats is not the thing that's going to be creating your fat issues. So what's like kind of the picture of the person that you typically would say, hey, this is a person who I think it's probably driven by more lifestyle factors who's going to have amenorrhea?
Yeah, it's kind of what you described, and maybe not a true athlete, but in my case, I was just a heavy runner, running half marathons with my dad. So it's someone that values their health. They take that seriously. They're eating really healthy. They do work out. They have a busy lifestyle like we all do. They have stress, but things are getting pushed too far where their quote clean eating is so narrowed down where it may not be eating enough or enough variety, missing some key nutrients or macronutrients, and then maybe too much exercise. So over exercising. And a lot of that is unintentional. That's the thing, is there is such a healthy mindset and it's all coming from a good place, but it's just being pushed too far. And I agree, the comment you made, sometimes it is coming from aesthetic goals. And that's where some real conversations have to come in of where we're placing the value, or our value. Is it just on our weight, or do we need to look at that and look at things from a different lens?
Yeah. And I also think that sometimes tying into the thyroid piece is that patients who already have underlying thyroid issues may be putting on weight, and they they maybe don't want to address the food stuff, so they turn to exercise and just think they can exercise their way out of a problem. And sometimes in that case can actually make things a whole lot worse for them.
Yeah, exactly.
Yeah, excessively exercising in a state where you're already in danger it adds to another danger response. And I think for the person who's saying, yeah, but I'm trying to do all these things to be healthy, how can this be unhealthy? It really comes down, as Robyn said, to balance. I mean, you can, if you're exercising, that's awesome, but are you over exercising? Are you allowing for enough rest and recovery? And that, as we get older, that really becomes more important because we just don't heal as fast or as quick. So it becomes more important. Is your diet good? Or again, as Robyn says, is it too narrow? Are you jeopardizing quality sleep and rest in an effort to make sure you get everything in, including your exercise? And that's one of the things that I was doing, for a number of years ago when I'm training for endurance races, training for triathlons. And, one day I run my blood work and I'm, insulin resistant, Hashimoto's, and, how the heck could this happen to me? I'm a dude. A, it's not supposed to happen to dudes. And two, I'm somebody who's eating well and exercising and doing this stuff. But then I had to look at the other side of things. Like, I'm still running a business, taking care of other people, their issues, have a family, coaching, and, then trying to, get to bed late because I'm doing stuff, and then get up every morning at 4 to make sure I get everything in. And in my mind at the moment, I thought I was doing all the right things. I thought I had balance, and I didn't really need sleep because I felt okay. But what happens is you can get away with that maybe a little bit more when you're younger and your capacity to heal and repair is a little bit better. But really, you're just cheating yourself. And what Robyn was talking about when she was like, hey, and sleep is so important. It is probably the thing is good quality sleep that has one of the biggest impacts on your overall physiology. And along with that, the other thing that Robyn was talking about was breathing. Mouth breathing is probably one of the biggest problems we see in people. And Robyn, I'll let you kind of speak to this because you already have the chuckle going, but it's cheap, it's free. Everybody denies they do it, but almost anybody with a health issue, especially anybody who's got a muffin top, I guarantee you're mouth breathing at night. You want to talk about that?
That's so funny you brought it up. Yeah, I ranted about this on Instagram the other day. So mouth breathing, I mean, there's a lot of info on this, and a lot of people are not unintentional, but they just don't know that they're mouth breathing while they're sleeping. And you're impacting not only the structure of your jaw and therefore chewing and a lot of things, but oxygen and carbon dioxide ratios. And, you get more antibacterial effects when you're breathing through your nose. And like you said, there's lots of metabolic stuff that come into play too. And it's a simple fix by just, this is going to sound crazy, but taping your mouth shut at night. And those inexpensive products, I use one called Somnifix, and I've been doing it for 2 years. I started it as an experiment and stuck with it just because I sleep better, I dream more, I wake up without a dry mouth, and I just like it. So it's an inexpensive way to hack your health by just taping your mouth shut at night.
Yeah, and I do the same thing. I mean, I've broken my nose 10 times, and I don't breathe through one side. Eric and I have talked about this on the podcast before. For the listeners, you have a nasal cycle. So your nose, especially at night, goes through cycles where one side's going to clog and the other one's going to be open and go back and forth. But we also have a tendency when we lay down at night for fluid changes. And if you already have inflammation, you're going to get even more fluid pushed into the periphery, and you're going to have narrowing of your nasal passages. When you breathe through your nose at night, you increase nitric oxide, you have antimicrobial effects. If you don't get good nasal breathing, vasodilation occurring, you don't get good carbon dioxide CO2 exchange, that is a danger signal. And as soon as you kick in that danger signal, definitely you're gonna change your chemistry. You're gonna increase cortisol, you're gonna increase epinephrine, you're gonna deactivate your thyroid hormone. You're gonna be telling your body, you're constantly through the night in a state of not getting enough oxygen to your brain. You're gonna have disrupted sleep. It is mouth taping, as crazy as it sounds. When I can convince people to do it, it's not, it's amazing how people go, I'm sleeping so much better. I feel I'm not even tired when I wake up in the morning anymore. I'm like, right, because you actually slept and recovered. I track HRV. You guys may track HRV as well. My HRV is different by about 20 points. The nights I mouth tape versus the nights I don't. Is that dramatic of a change? So
Yeah.
I'll be in the 60s to 70s. And if I don't mouth tape and wear a nasal strip, I'm down into the 40s. Now add a glass of alcohol to that, and you're in trouble. But it's one of the simplest tools, and it's one of the simplest things you can do for your overall health. And most people don't want to do it.
Yeah, that's the key, is people don't want to do it. I just had a conversation yesterday with an IBS patient. She's like, I sleep fine. I don't have any problems. And I was like, but you have digestive problems, and you don't understand that sleeping with your mouth open all night changes the microbiome in your mouth, which is going to change the microbiome in your gut, and they play off of each other. And so she was like, she kind of looked at me with that, like, I don't know if I believe you type of thing. And I'll keep working on her, and hopefully we can get her to change it. But that's the thing, is trying to get people to do it, because they think it's crazy, but it's free. It's free. Yeah. You could buy the strips, the Sauber strips. Those are great, but you can also just get a little piece of 3M tape, and you can tape your mouth shut. That's a good starting point too.
Yeah, I think we need more selfies going around Instagram so that people normalize it a bit more. So you guys in?
Yeah.
Yeah, I'll have to put it on there. It's funny. I thought about that last night. I'm like, as I'm laying in bed, I got the nose tape on, mouth tape on. I'm like, man, I should take a picture. I'm not the most attractive person to look at, so I'm not sure if it's a good idea, but you guys definitely. But I should put a picture on there and get on it. But for the listeners, I'm telling you, when I ask people, do you think you mouth breathe or snore? Everybody says, no, I don't think so. I'm like, well, how do you know? Because you're sleeping. Well, I would know, wouldn't I? No. The only way you're going to know, you might know if you wake up and your mouth is pasty, if your dentist has told you that you've got gum disease or you have cavities, you get up in the middle of the night to get a drink, if you're getting up multiple times a night to go pee, if you're waking up tired, you're waking up fatigued, groggy, you're probably mouth breathing at night. The only way to really know is have somebody stare at you while you're sleeping, which is a little scary, right? If you wake up and go, oh my gosh, you can take video of yourself. But I've even told people, just put the tape over your mouth. And they're like, well, the tape stayed on there, and so therefore I'm not opening my mouth at night. I'm like, yeah, but how did you sleep? Oh, I felt better. Okay. Then you were mouth breathing, and the tape kept your mouth shut, right? So there really isn't a good tool, but this is a cheap thing. And I know we got away from amenorrhea, which is our topic, but this plays a role. As Robyn was saying earlier, amenorrhea is typically going to be triggered by some type of stress or danger response, something that's telling the body, hey, we do not need a period. And it could be just years, months, weeks, years of poor breathing. And that's key to one of the triggers why you might develop amenorrhea. And I guarantee you, your gynecologist is not going to be thinking, most gynecologists aren't going to be thinking, hey, this could be a respiratory issue, right? I just don't think that's a main thing that's going to come up.
No, but it's part of the big picture. Definitely part of the sleep picture and stress picture. So if we can get more people mouth taping, we're helping the world.
Right. So I'll tell you what, we're coming to the end of our talk for today. So for the person who's sitting at home, they've got amenorrhea, they've been told that, hey, this is just normal. Some women just don't have periods. It's okay. You're not planning on getting pregnant anyway. It's normal birth control, so don't worry about it. What kind of advice would you give them regarding how to take the next step? Obviously, they're now understanding that amenorrhea is not a normal situation. It's a sign of a problem. What steps would you tell that the person who's at the other end of this other end of this podcast as the steps to do?
Yeah, my tips would, if you're being told it's normal, either find a different doctor or look into a functional medicine doctor or provider, someone that can dig deeper through all the things we talked about today. Because like I said, it's not one answer. Just because you have amenorrhea doesn't mean you need to do one thing. You need to find out what your cause is. And it's gonna take some digging, either on your own or with a provider. And I have resources for people to do it on their own, but there's definitely ways that people can partner and get more tests and, help with a different lens looking at it.
Erica, any final comments for today?
No, I think this is a great topic because they goes very much in hand with thyroid issues. And so I think it's a great topic.
Yeah, so we appreciate you coming on, Robyn, but can you give the listeners, we'll post some of the information, but if the listeners want to get more of your information, where can they find you?
Yeah, so my website and all my social is Nutrition by Robyn. So that's ROBYN. And then I've co-created a course with another functional medicine dietitian called Her Hormones Academy. And this is where we help people dig through their specific reason. And Amenorrhea has its whole own module, and we help people kind of weed through what their reason or root cause might be, and then help them with the solutions there. So that's another resource for people.
Awesome. So we'll sign off on today. We appreciate you coming on. Maybe we'll have you come back on in 6 months or so and discuss another topic. But thank you so much for coming on today's podcast. And for the listeners, check out Robyn's information. She's got some great visuals on her stuff. I'm not sure who's doing her picture taking, but they're doing a good job. And if you enjoy the podcast, share the podcast with your friends and family, and also go to iTunes and give us a nice rating. Any rating is probably good, but we'll take the 5 stars, probably the best. All right, so we'll sign off for today. Thank you, ladies, for coming on. Robyn, thanks so much for coming, and definitely check out her coursework if you've got hormone challenges. All right, take care, everybody. Look forward to another Thyroid Answers podcast coming up soon.
See ya.